Well, hello there. I'm Jim Hoover, and I'm happy to discuss my views on algorithm bias. This is a big topic. It's not black and white either, so there's a lot of nuance in the things we're going to talk about tonight. The simple truth is that computer systems do have built-in biases. It's racial, it's gender, age, or any other thing you can think of. The good news is, we in the health information technology industry and HIM industry and informatics are beginning to understand and recognize the signs of these biases. And we're developing techniques to find them, even better, prevent them from happening. But sadly today, the biases do exist and probably will continue into the future as new systems are developed. So sit back and enjoy. My contact information is at the end, and I certainly will appreciate any questions or feedback you have, so please feel free to contact me. So my nickname is Jim, computer scientist by training, a master's degree from Johns Hopkins University in Baltimore, Maryland. I've been in this industry about 10 years. And you'll see by the presentation that I am a bit of a technology nerd. So, be forewarned. I direct the research and product development for my company, Avant Health Sciences. I'm a very active volunteer in the California HIM Association. I'm the co-chair, for example, of the editorial advisory board that publishes the CHIA Journal quarterly. I'm also the principal author of the CHIA EMPI Toolkit. It's 80 plus pages of modern techniques to help prevent and clean data errors in EMPIs. And finally, I'm writing 2 textbooks on health informatics, one on patient match and one on health information technology. Small disclaimer here, I did my best to do research and give you some original ideas about what's going on and collected all kinds of industry background to help you understand the problem. But I implore you to do your own research. So in my spare time, I'm a patient matching subject matter expert. It was my first entry into healthcare IT, and I'm still very active in research development and problem solving in that area. And I want to share with you when I first detected human bias in healthcare algorithms. We had a patient matching machine learning solution that used artificial intelligence to train on records that were matched by credentialed HIM professionals, RHIAs, RHITs. And after we ran through the training, we do an analysis of what features, as they're called, are most important in matching. What we found was that date of birth was a significantly more important factor than any other feature in the dataset for patient matching. What this means is that us as humans highly favor the date of birth as the most important indicator for matching. But that said, the date of birth is not special, and there are just as many errors in dates of birth fields as there are statistically in other fields. So this bias led us to possibly not find patient matching records simply because we were looking at date of birth as the indicator. So it's a wake-up call where if we can detect something that simple from our training data that drives our healthcare systems, I started to think, what else is out there? And oh boy, did I find a lot. So before we go any further, let's define what a bias is. It's a prejudice in favor of one group or another, and we often consider these biases as unfair. The biases themselves can be either conscious or unconscious, explicit or implicit, and the conscious bias holders, they're well aware of their thoughts, of their opinions, and they hold their beliefs with intent. They like to often let others observe and understand their thinking. The other side are the unconscious biases, and these are the biases that we're not aware of. It may even be contrary to what we think we believe, but our actions and thoughts often are not what we intend them to believe. And these are very difficult to detect because they're not out there in public to observe by others. Before we get to algorithms, let's talk about photography. I have a question for you. Can photographic systems have biases? That's the question. I'm going to pick on Kodak here because this is a well-publicized case. And the reason I'm going to pick on Kodak is because they were well aware of a problem that existed for years before they tried to solve it. But we have to go back way back when I was young, and they had film actually in cameras. Many of you might not remember this. Once you took a photograph, the film was sent to a processing center, and that processing center would develop the film and create a print from it. And those enlarged pictures from the little negative are what gave us the prints we hung on the walls or shared with our friends. The source of the bias happened to have been in the manufacturing specifications of the film and the chemicals that were used to process and develop the prints. And then lastly, the reference of what was a good print and what was not. The human eye can see light in a specific range, which is very big, but film typically will see in a much smaller range. The better the film, the more expensive it is to manufacture, the bigger the range. The problem with Kodak was they knew that the film range was not big enough to capture photos of people with darker skin versus those with lighter skin. And it's a problem they ignored for years. There was not enough detail captured, in other words, in the image. The problem can be solved, however, with a more dynamic range of the film. And it's something that Kodak took a long time to solve. And they only solved it, I will tell you, when furniture manufacturers and candy bar makers complained because photos of the darker woods and dark chocolate did not have the same amount of detail as lighter products. And so Kodak listened to the manufacturers, but unfortunately not to the people. The photo labs, where we drop the film off, would process the film and give us these little envelopes. And we would take the film out, and they would put it into an enlarger and make the print. The problem with the systemic bias was that the reference for the prints was just a beautiful model who happened to have really light skin. And this reference was called the Shirley card because the original model's name was Shirley. So you can imagine photos of people with darker skin had no reference of which was a properly developed film. So on top of film that did not perform well with darker skin, there also was no reference for the processing of those photos. And as you probably can imagine, that bias carried into digital photography. The performance envelope of film was largely emulated by digital photography. This is an example how a bias from one system can be carried over to another, repeating the problems of film, but now with digital photography. Now, most consumer cameras are in the phone. And the phones actually can do something special, as it turns out. We're entering to the world of computational photography, where this is a little handheld computer that happens to process the film, or the photo rather, in real time to correct the colors, to correct the exposure, to stabilize the image, and so forth. And this processing is also something now that we can do, as led by Google, to create better images of those with darker skins. So we are now finally fixing this problem 70, 80 plus years after it's been known. And Google's phone, and even Apple's now, are doing corrective measures through computational photography to have better photos of darker skinned subjects. So let's bring this into the healthcare arena. Photographic bias actually has major healthcare implications. If you think about dermatology, for example, it's obvious photos that do not produce good images for darker skinned patients will also impact patient care. But there's even more biases as the story is told, the collection of clinical images, dermatological conditions, are predominantly from light-skinned patients. There's a data selection problem as well, not just a photographic problem. And this is where systemic bias comes in again. The industry, collectively, is responding through social media, though. There are some accounts on Twitter and elsewhere that are starting to collect skin conditions on darker-skinned patients. And that's becoming a clinical resource, even though it's not an official medical publication. And this is really critical because darker skin doesn't show the diseases in the same way that lighter skins do. It just looks different. And as a result, it causes misdiagnosis at a higher frequency rate on darker skin patients versus lighter skin. So there's a real patient impact here. And you're probably asking, when is he going to talk about algorithms? Well, I've set the table. This is not a talk on health equities, not a talk on photography, but it's a talk on how algorithms repeat a lot of these same problems we see in both photography and the health equity issues. And photographs are a wonderful way to visualize the problem and really understand the problem for something that's so abstract as understanding what an algorithm is and how it can have a bias. The Shirley card, for example, illustrates what happens when you underrepresent a patient population in your data. It should be very obvious we don't have photos of darker skinned models in our reference. Those photos probably won't come out so well. And in the same way, if we don't have data in our models for different patient populations, the system that's used to detect and or give treatment for those patients probably won't have as good of outcomes as those that it has data for. And this is called bias in our data selection. It's either conscious or unconscious, and it shows us how systemic biases impact patient care. This also happened in facial recognition systems, because the first software developers who built facial recognition software 20 plus years ago, most of them look like younger versions of me. White males were software developers, not a lot of women, and not a lot of people with darker skin tones. So what happens when those developers used training data for facial recognition? They pick photos that look more like them and less like the young lady on the screen. So as a result, facial recognition performed poorly for women and for people of color, and probably older people too. And this tells us that our data has to be representative of all the demographics of what the system intends to serve. So now let's define what are algorithms. Algorithms control everything on a computer. Your screens, how the windows appear, what jobs are running, whether your emails go out, whether your browser brings back the web page, all of that is controlled by an algorithm. Algorithms are like recipes that follow instructions using the ingredients that are specified to make a dish. And in similar ways, the ingredients are the data that are input to the algorithms. And the logic of the recipe, the step-by-steps of the recipe, are the logic of the algorithm itself. But instead of making a cake or a pot pie, we're producing some kind of output from a computer program. Now, I've gotten this question many times before, and it's actually a really good question. I thought computers had no emotions, no judgments. Aren't they the perfect tool to implement fairness? Well, unfortunately, computers are programmed by humans. And humans, as we talked about at the very beginning, can be biased, conscious or unconscious. And further, sometimes we just make mistakes. We have bugs in our logic, and this happens frequently in software. Errors can be subtle and very difficult to find, and thus they persist for a long time. Then finally, as we talked about with the Shirley card, humans pick the data as well, and that process, if not representative of our patient population, will bring bias to the systems. And that was illustrated by the machine learning that I opened up the conversation with for patient matching. The biases in computer systems are most likely to be implicit, unconscious bias, or faulty logic in the system code, under or over data sampling. And software testing does not always find those problems. I read a very good paper recently from Verheul and et al. And that gave a well-researched list of possible bias sources that are in EHRs for using the data in the EHR for medical research. And there's many points in the system: the revenue cycle side, the data entry, clinical guidelines on how to use the EHR, the ease of which patients can access their own data, how data is shared between providers, how busy the providers are, and the inconsistency of how data is represented in different EHRs and how they're shared, the knowledge and education of the users who use it, the tools to extract that data and how to process it, the research methodologies, and also on what the data is going to be used for and how it's prepared. All of these things contribute to data errors and bias in EHR data for research. I want to step you through a real-world example. It was in Science magazine, and it dissected the logic with the help from the vendor for a clinical decision support system. And it was found to have a very bad logic flaw. The software company, they had a developer or team that made a logic choice that created a very big problem and impacted the minority population of patients by disproportionately recommending the treatment to white patients and not other minorities: Hispanic, Black, Asian, Pacific, and so forth. For this clinical decision support system, the manufacturer needed a way to determine the illness burden of a patient. So they did what they thought would be a reasonable thing, which was to just use the amount of dollars spent on the patient's healthcare as a proxy for the illness level of the patient. With the logic being, if you go to see a doctor more often, you're going to have more expenses than those who don't go see the doctor, and therefore you're sicker. The logic makes sense on first blush. But the problem comes in, however, you consider the fact that there are health inequities, that providers are not always available to those that have transportation issues or live in underdeveloped areas, bad socioeconomic conditions, and so forth. And therefore, that patient population are less likely to get the health care that they need just because it's not available as easily as those who have more means. Thus, those patients had less per capita spend on healthcare than the white patients. And as a result, the minority patients, almost without exception, had much lower healthcare expenses and therefore were considered to be not as sick as the white patients. And that faulty logic of the correlation of healthcare spend with illness burden was simply not accurate. The logic doesn't account for that limited access. Less access to healthcare means that this clinical decision support system will not recommend the procedures to the minority patients as often. Clearly, there are better ways to measure a patient illness, more fair and without bias. The researchers partnering with the company actually looked at each patient's medical records, the blood work, and so forth, and they found a much better method to determine the illness burden of patients. Biomarkers in the patient's blood work that were higher for the sicker patients and lower for the patients not as sick. And when the researchers used this new method to predict which patients needed the care the most, the balance of recommended care to non-white patients increased significantly. In fact, this is all self-reported data on race and ethnicity. Black patients had a higher illness level, 4.8 versus 3.8 for white patients, but received a lot less care. And this approach of using a multi-dimensional data analysis to help figure out which patients needed the care is really a much more robust way to deliver healthcare and recommendations for treatments. And this example shows us that the inequities of healthcare access perpetuated limited access to treatment, even when the minority patients got to the clinical decision support system, because of that faulty logic and bad assumptions. The medical care was impacted significantly for the non-white patients. Now we know that software logic can have faults. And this example, by the way, is really rare. Very few vendors are willing to let researchers access their logic, their algorithms, their code, and partner with them to help find flaws. So not a flattering thing to find this out, but this one particular company really should be applauded for the effort. In the world of software and enterprise systems, we think of blameless environments so we can find faults easier and quicker. And we have to give all the credit to this software company for allowing the researchers to do this. Not to say it was easy, but it really should be applauded. Biases also come from training data, machine learning, AI systems. The data comes from patient medical records. And we talked about the issues with EHR data earlier. But the most important factor is the data is selected by humans, the images or the text data. So let's talk about facial recognition. It's notorious for having lower accuracy rates for non-white faces because the training data is selected by people that look like younger versions of me. White males are the predominant labor in the software market. So as a result, photos that look like me are oversampled. There's more of that kind of data than for minorities and for females, etc. This is a well-known programmer bias that has existed in facial recognition for some time, although it's gotten a lot better. But it's one of the first areas we recognized where AI can have problems because of the training data. There's been a lot of research on health inequities and data biases in healthcare. And the bad news is there are a lot that have not been uncovered yet. And all of us should be well aware of it. But I want to give you two other ideas of racial disparities in healthcare that also may impact treatment. There's been a lot of research on inequities and data biases in healthcare. And the bad news is, unfortunately, we're going to see more of this. Our current EHRs, clinical support systems, and AI systems all have biases, and we keep finding them all the time. Some of what I'm going to say in this presentation might be a bit controversial because there are certain beliefs about the human body that are divided along racial lines that's just not true, at least according to most medical science. The false belief about skin thickness, for example, with African American patients and how blood coagulates is something that 40% of residents in 2016, not too long ago, falsely believed. Gave way to the belief that black patients would feel less pain than white patients. You can imagine if the clinicians think this, have an educational problem as well. These implicit biases are firmly ingrained in a lot of society. The fact that the doctors are applying these medical heuristics contribute to these healthcare system failures. I'll give you 4 examples from a Kaiser Family Foundation study that were taught in preclinical lectures that continue to introduce bias into our healthcare system. The first one being that cystic fibrosis was discussed as a predominantly white person's disease, and putting that knowledge into clinicians' heads almost undoubtedly mean that non-white patients might get misdiagnosed because the clinicians are thinking that it's probably not cystic fibrosis. There's other falsehoods about black patients are more likely to have certain diseases than other populations. And as Kaiser pointed out through their research, that's not the case. 2 more examples from Kaiser, just to give you an understanding that these thoughts are not isolated. We talked about dermatology before, and Lyme disease is one of those diseases that you can discover on the skin. Because of undersampling of data, it has been primarily detected in white patients, not darker skinned patients. But the really most shocking thing to me was about the depiction of black patients for sexually transmitted diseases were much higher percent than the population. So that illustrates a strong selection bias against black patients in this particular example. In almost no other disease state are they oversampled, except for sexually transmitted diseases. I want you to think about that for a minute. So now that we know that the systems can and do have biases, we know that clinician training programs can and do have biases. What do? How do these biases get into the systems? And this requires us to have a better understanding of software systems. Now, practically speaking, these teachings become part of medical knowledge, and that medical knowledge impacts the health IT systems because those doctors are indeed the ones helping the developers to build software. And also, the software developers read medical publications to learn about the conditions that they're trying to test for and make decisions about in software. So the problem is widespread. Clinicians, data scientists, computer scientists, software developers all drive the selection of the training data and the logic. There's also disparities in collecting the data, not just in how we use the data. Genetic databases and legal databases are really great examples to illustrate these biases. Many studies have shown there are structural disparities in collecting biomedical research data along ethnic and racial lines. The majority of DNA samples, for example, are from individuals of a European descent. Asian, African, Latino, and Aboriginal groups are underrepresented in these DNA sample databases. However, just like with sexually transmitted diseases for Black patients being overrepresented, guess what? In the legal world, the DNA for suspects and criminals disproportionately represent the Black population. In fact, the ratio is about 2 to 3 to 1. Black DNA in our legal system versus white DNA. Again, pause and think about that for a second. So this leads us to a real need to understand implicit bias, both from a clinician's perspective as well as from a data perspective. There's a test online that you can take called the Implicit Association Test, and that measures up to 61 implicit biases through a series of questions that the respondents just answer good or bad, as well as the time it takes to answer the question. So you can't game it by trying to think, oh, is that a bad thing or good thing? Because it's measuring how fast you reply. Among the physicians who took this test, females, no surprise, turned out to be less biased than men, because they're nicer. I'm sure that's the case. But one of the more interesting things that I found from reading the studies was that pediatricians tended to be the least biased of all physicians. In all the tests, physicians included lawyers, construction workers, policemen, software developers, everyone. There was a strong preference shown for whites than blacks in the data for this implicit association test. And before we get uppity and think that education would solve that problem, no, the data does not show that. Even among highly educated respondents, MDs, JDs, PhDs, and so forth, those biases still existed. Implicit biases. And I strongly encourage everyone listening to this video to take a look at the IAT test yourself. It's on Harvard's website, and the link is provided. There's a wide variety of areas that you can test your own implicit biases. Religion, science, gender, race, sexuality, weapons, and so forth. And as it turns out, more than 70% of the test takers show an implicit bias. Again, it's not what we want to think, but it's what's inside in our programming in our brain that's coming out through this testing. So if that's the case, 70% of the respondents have a bias, then we could probably estimate 70% of our software probably also has a bias. Follow the link, pick a subject for yourself, and test it out. It doesn't mean that we're bad people. It just means that we have to recognize this and then build systems to correct for it. Let's continue down the line of looking at physician implicit biases and look at clinical notes to get an understanding of how we can study those. This data is unstructured and analyzing can be difficult. Clinical notes are used for decisions in patient care, software and humans, and incorrect conclusions can be drawn by the words that are in those records. Words like aggressive or combative, resistant, refused, or difficult will have profound impact on the perceptions of patients downstream. In 2020, there was a study on clinical notes that found Black patients had 2.54 times more negative comments than white patients in their notes. 2.54 times more negative comments. For Medicaid and Medicare patients, there was 2.66 times more than non-Medicaid Medicare patients versus like privately insured patients. And there can be a little humor in this too. It's not just dry and difficult to discuss, but one I found to be somewhat comical was unmarried patients had more negative comments, 2.12, versus married patients. So maybe it's true, it is better being married than not married. I don't know. Negative comments have been analyzed and detected in clinical notes. That is another example of implicit bias in our systems. Also of note is where the data is collected. What is the geographical location of the data that's being used in the systems that are given medical treatment? There was a study from locations for data sources on a peer-reviewed publications that showed California was used in 22 of 56 studies, 39%. Massachusetts, 15 studies, 27%. New York with 14, that's 25%. And 34 states didn't have a single patient in the cohort of all 56 studies. Now, healthcare data needs to be trained on age, race, gender, and geography if we're really going to get accurate representation of the population. So there's biases also in geography. The implications of this data location bias can be significant because there's big areas of the country that are not represented in medical studies. This could potentially impact behavioral, ethnic, or educational, or other locality issues, all related to health. For example, smoking, or occupations, weather, or diet, or industrial accidents, pollution, so forth. And artificial intelligence systems use data for machine learning. And those systems might not be able to generalize properly because it doesn't have an accurate picture of the entire population, just like the Shirley card. Good algorithms, in fact, must be trained on a diverse data set. And we have to be really mindful of that. And why this is so important, the data, it's because how the machine learning systems actually use it to train themselves. And that's also applicable for natural language processing systems too, both of which are 100% dependent on the data quality. But as we discussed, the system is only good as the training data we give it. So let's explain how machine learning works. We model the human brain with what's called a neural network, and that's supposed to create connections between two neurons, as it were, and our training data reinforces or subtracts these neural connections. We will take our training data set divided by 5, 20%, and we'll do 5 training sessions of 20% training, the rest of the 80% testing, and then substitute each new section of 20% until we've trained everything, validated the model. That's a very common way to train and test neural networks. And these neural networks, quote unquote, learn by strengthening the connection between the neurons. Simple concept. And to go back to my very first example about patient matching, we would give it 2 records that are matched by a human, supposed duplicate records, and train it to say this is what duplicate records look like. So the challenge is when we have biases in our data for the date of birth, for example, that's what the system learns how to recognize. And it trains the weights on these neurons. The system learns that dates of birth matter more than anything else, and that will absolutely impact our classification of match or no match for every suspected duplicate pair going forward. Okay, so we've talked about nothing but bad news, more or less, about biases in humans, photography, and healthcare systems. But now we can start to understand how to prevent those biases from happening. Just like Smokey Bear would say, only you can prevent forest fires, the same thing. We have to attack the rules of thumb, the heuristics learned in medical schools. We have to attack the faulty logic in software, and we have to attack the problem of how data is selected for systems to prevent those biases from happening. There was some more research from Kaiser Family Foundation that I thought was really illustrative on the problem. And what their hypothesis was is that race does not present an accurate representation of the human biological variation. Race does not provide an accurate representation of the human biological variation. Man, what a beautiful, beautiful sentence. Complex but beautiful. And what they dig into is they say race is not a proxy for genetic diagnosis. In fact, they've shown that large studies have a greater variation within racial groups than between racial groups. So as a rule, system developers must move away from race as an input. It doesn't mean we don't test for bias with race on the output, but in terms of input, the differences rather are correlated more along social determinants, which is what we are now starting to collect in much bigger way. It's much more important. We look at things like food security, transportation, household income, how many people live in a household, healthcare access, and so forth. Those are what determines health. Another approach is to adopt what's called an AI fairness model. And this is something all system developers should consider. To that end, there's an AI fairness toolkit that helps developers figure out if their machine learning systems have some inadvertent biases in them. And you, as HIM professionals, you're not necessarily going to run these tools, but it's a great question to ask your vendors. Did they run it through the AI Fairness Toolkit? This is fairly in-depth algorithm work, and it's way above my pay grade, but it's worthwhile for us to know about. Another methodology for remediating the biases in algorithms, it's just testing for it. It's not something that's being done often. There's a reference I included from 2020 that suggests building two different versions of the model, one with demographics and one without. So the output can be tested for unexpected race, gender, age, or other biases that aren't expected. And then the next thing to do is to test the algorithms with only one group of data, a specific race, a specific gender, or another label. And then compare the results with the entire data population to see if the results are the same, or if they don't vary too far from each other. And as you create new models, make sure that variance stays consistent, so you're not increasing the bias. If anything, you're reducing the variance to take the bias away. Requires a lot of optics to understand this, but it's very doable. And along the lines of that margin, the variance of the bias, we can develop a metric that measures it and run the model for two different races, two different genders, and see how that variance changes between these different inputs. And if that metric changes too much, that variance changes too much, if we run it for white patients, Hispanic patients, black patients, and Asian Pacific Rim patients, then we know that the algorithm needs some work or the data needs some work. And then finally, I think this is a brilliant idea. Anytime a bias is detected in a system, we should treat it like an adverse drug event, a protocol that is used in the hospitals. And we should respond to the safety risk for the algorithms just like we do when there's a medical issue. We establish timeframes to respond. We have a communication protocol for the errors. And we prescribe a resolution for the patients, the clinicians, and any other stakeholders. What we're really trying to do is mitigate the response time to correct the problem. Again, a blameless environment, but a focus on getting the patients healthy and removing the problematic issues in the code. So we are now at the beginning stage of tracking these adverse events. And there's a system that's called the Partnership on AI that has several programs to address these challenges we're facing. It's funded by IBM, Amazon, Adobe, Google, Intel, Meta, and others. And even just this year, 2023, there were 3 reports of AI issues, coincidentally all in mental health, and errors that have occurred or problems that have occurred with the software in dealing with patients. One issue that caught my attention was number 123 back in 2021, just where an independent test of Epic's AI sepsis alert system uncovered a huge gap between what Epic claims was its performance versus what the real-world performance was. So this is a monstrous issue for patient safety. But Epic, as it turned out, only found 33% of the cases, but yet it claimed an accuracy rate of 76 to 83%. So a huge gap between what was reported and found in the real world versus what the vendor claimed in marketing hype. And the fundamental finding was 67% of those sepsis cases were just missed by this AI tool. So that's a serious patient safety issue. More bad news for Epic's tool is that 88% were false alarms. So that's going to lead to alert fatigue, having to spend a lot of money on tests and clinicians' time, and ultimately those alerts are going to be ignored. That's a big, big challenge. And there's some initiatives by the federal government that's coming out to try to begin to regulate the AI usage in healthcare. The National Institute of Standards and Technology has published a concept paper on AI risk management framework, and the Food and Drug Administration have also created an action plan on how to validate AI software with a big focus on algorithm transparency and real-world record keeping, just like the FDA requires for drug discovery companies, and regulating the software as a medical device. These are just possible areas where regulation may come. The FDA has also published a paper called Good Machine Learning Practices, and it's modeled after the current FDA Good Manufacturing Processes, the guidelines for medical devices. It was interesting to see how FDA is taking hardware approach to software problem, but maybe that rigor will help us improve the quality of the software. They're focused on real-world performance metrics, like the sepsis example we gave earlier for Epic. Not what the vendor claims, but what's actually performing in real life. Now, last time I checked, the FDA was developing a methodology for evaluating and improving machine learning systems, including eliminating bias. We have some of the smartest people in the country working there on these problems. Pundits out in the industry are also starting to call for action. The Harvard Business Review has predicted that all AI should be explainable. That's their position, what the regulation should be. And this explainable AI is something that a new area for artificial intelligence tool builders, and it's difficult, but it might happen. But understanding the weights inside the neural network, like we showed earlier in our demonstration, is notoriously difficult. So explaining how it works and how the decisions were made is going to be hard. Just to understand the difficulty in testing AI systems or understanding how explainable AI will work, you should probably understand that there's really two types of systems. There's rules-based system like logic, like the CDS we talked about earlier. It's very clear to understand: if this, then do this; if that, then do that. And then there are learning-based systems like AI tools, machine learning. And those tools discover through the data training how they should process new data. So there's no rules or no logic to really understand, other than just trying to figure out the pathways through the neural network that were strengthened because of the training data. Sounds mysterious and difficult, I fully get that, but that's how they work. There's no illustration, no way to really clearly understand what a certain weight on a certain neuron means. You have to understand the entire system. Some recent papers have come out, 2021, that recommend some methods for removing biases from systems. In the paper, it was suggested that, again, remove race from the input, just like Kaiser Family Foundation was suggesting. And also try to locate or identify input data that's highly sensitive to change, and try to normalize the scale of that data so the system's not so sensitive to that input. The article also suggested, I think optimistically, to try to adjust those complex neural weights. That's harder to do than it sounds. And then also use some of the AI fairness tools we talked about earlier. Sometimes they're called prejudice removers, to try to restrict the machine learning's capability to interject those biases. And I'm sure you have heard of ChatGPT-3 and understand that was trained on much of the data on the internet. And you can imagine all the biases, the political arguments, the racists that are arguing. And as a result, ChatGPT-3 had to be detuned to remove some of that unsavory content. So that is possible, albeit difficult. And another very clear approach is to start at the near root of the problem, the data selection. A recent JAMA article suggested that system builders should be careful on data selection, of course, and the sources of the data. Think back to the geographical disparity issues. Care should be taken by the tool builders and verified by the HIM users, providers, that the patient data and demographics that the system was trained on match your patient population, and should include social determinants for these healthcare considerations. JIM also recommends that all the AI systems that you use have been validated externally by someone, not the vendor. Like Epic was validated by researchers and found to be way off what was promised. In a similar way, all AI, because Epic is not alone in this, all AI should be validated this way. We also need to pay close attention to the algorithm designs themselves to prevent biases. This will require a fundamental change in how systems are developed, because the method, the techniques, the tools that are used to put together solutions are proprietary and a competitive advantage for companies. If we're going to prevent biases from happening, we have to consider this as maybe something that is regulated. We have to share the documentation of the model so others can check it, just like we do with security. Systems are secure only because external parties validate that the algorithms for protecting the data are not breakable, at least easily. Same thing with the users and the training methodologies, how the data was selected, the architecture and input features. All of that should be published or at least made available for researchers to try to ensure that there's no obvious biases going into the model. We should also fully understand that missing data is also a big impact on the validity of models. For example, with patient matching, the less data that's available, the easier it is to match. But that doesn't mean two Juan Garcias or James Hoovers living in the same city are the same person, because the chances are they're probably not. Missing data creates significant biases, for sure. I've seen it in patient matching and other algorithms. So we have to be very cognizant of this. The good news is, at least, that there are some techniques to correct for missing data. And I'll give you one example that's used for imputing when systems are missing race or ethnicity data. And that's valuable for certain reports or applications, and certainly valuable for validating the algorithms. That's what we've been talking about consistently for this entire presentation. There's a Rand Corporation method called the Bayesian Improved Surname Geocoding. It's a mouthful, but what it means is they're using artificial intelligence to predict the ethnicity and race based on the person's last name and where they live. And this approach is significantly more accurate than just using surname or the location where someone lives alone. So we can use this technique, at least for race and ethnicity, to impute those values and use that for testing or validation or what have you. And in similar ways, we can find techniques to also impute missing values in our data for training, or eliminate that data from training so it doesn't have a negative impact on our model, and we don't introduce that significant source bias. The last corrective measure I want to talk about is that algorithm transparency issue one more time. We know the more eyeballs on an algorithm, the more likely we're going to find a problem with it. The American College of Healthcare Executives suggests algorithm transparency very strongly, as well as explainable AI versus black box systems, which are things we don't know how they operated inside, typical machine learning systems. They also recommend understanding the full impact of the input features. Just as I described to you earlier about the impact of dates of birth on influencing future patient matches, the American College of Healthcare Executives want system designers to understand the impact of all the inputs. And the rest of the world is not standing by while the US is trying to figure it out. The European Union, for example, already has regulations for explanation that's part of their General Data Protection Regulation, GDPR. U.S. credit bureaus already do something similar when they provide explanations for credit denials. So this is why that Harvard Business Review prediction that all AI systems in the future should be explainable, that's where they're going, that's the trends that they're building on. To really understand algorithm transparency, we have to do a deeper dive on the context in which the algorithm runs, what's its purpose, and the socio-political environment that the algorithm was deployed, because that might have some inherent biases as to its origin. Who was involved and what are their interests? For the input, we also don't just focus on the data, but we have to understand how we filter it, how we normalize it. Are we dropping important data from the model that it turns out we should not? Or should we drop something like race, for example, as recommended by Kaiser and others? Understanding the process to move and manipulate data is one of the elements we talked about earlier about EHR data used for research. How we process it and the methodologies are critical to understanding algorithm transparency. We also have to understand how to react and what to expect from the output so we can find out when it seems to be incorrect. And that goes back to the PAI and FDA recommendations. Sometimes we do need a human in the loop. It's one of the things I strongly suggest in patient matching. We never remove the person from the loop. We have to look at the design choices of the neural network itself, how it's organized, the number of internal layers, how do they communicate? Are there any internal feedback loops that amplify input, or negatively or positively? Are certain paths being boosted? Like on patient matching, if two names match exactly the same, we might boost the score, for example. And then finally, we have to look at how does the algorithm input others? Are patients who need treatment not getting it, like in that CDS example? Or is it likely that disease diagnoses are going to be missed? For example, in dermatology, images not being available for darker skinned patients, or data not being available for certain areas of the country. And look, it's not all bad news. The systems are getting better. We are becoming more aware of the situation. Our society and our technologists, our healthcare executives, and our political leaders are moving more in lines and being more in tune with health inequities and how that impacts patient care, also how it impacts system design. And older systems are being replaced with more modern ones. Sometimes the algorithms are good. There was a recent test of a pediatric sepsis alerting algorithm that was found to be better at performing than the human staff. And this was specifically as it applied to non-Hispanic Black patients versus others. The software actually narrowed the inequity gap. So that's a great thing. Algorithm biases do exist and will continue to exist, but they're getting better. Okay, we've made it to the end. Give you some closing thoughts, and I appreciate all your attention to this obscure, detailed, but very important topic about protecting our patients from bad algorithms. There is a general consensus building in the medical, biological, genetic, anthropological sciences is regarding the lack of connection between race and disease state. So that is big takeaway today. Health information professionals, health informaticists like myself, and healthcare IT developers all must ensure that the outcomes from data analysis and the algorithms do not vary by race. That's really critical. Finally, we have to look for hidden traps, dig deeper into the system inputs, the training data, and the logic, hopefully with more transparent algorithms to detect when things go awry. With that, I want to thank you deeply for paying attention. Hopefully you learned something. This is an important topic. I've covered as much as I could in an hour. There's a lot more to this and a lot more depth. I'm available as a resource. Reach out to me. Connect with me on LinkedIn. Follow my post or what I'm thinking about. Ultimately, let's work together to protect our patients. Software is not perfect. In fact, it's quite fallible, just like we as humans are.